Hello, beautiful people. Welcome to this week's episode of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, your community radio station. I'm your host and producer of the Happy Hour, Olga Peters, and we are talking today about healthcare and healthcare costs and healthcare options. And we're going to be talking about them with regular contributor Emily Kornheiser. Hello, Emily.
Hello, and good morning, Olga.
Good morning. Yes, we are pre-recording in the morning, in case you're wondering about this lovely light that's waxing over all of us. I want to welcome to the show Mike Fisher, who is from the Office of the Vermont Healthcare Advocate, which is under the umbrella of Vermont Legal Aid, and they're a free resource for anyone in Vermont who has healthcare questions. What is the best plan? What is the most affordable plan? What am I eligible for? How do I solve this billing dispute? Anything like that, you can take to the Office of the Healthcare Advocate. And so glad you can be joining us today, Mike.
Good morning. And why don't I just respond right off? Advice for people who are listening to this or any other presentation on healthcare. Hey, we're going to say things today that you might say, hey, this affects me. What should I do about it? My general message is, don't take advice about your own personal situation from somebody on Facebook or on a show. You got to call somebody who can walk through the situation for you. And there's a number of people in our community that can help, communities that can help with that. But my office, the Office of the Healthcare Advocate, has a team of advocates who are on the phone, not quite at this time of the morning, but who are on the phone every day, helping Vermonters, negotiate, navigate this horribly complex system and give advice for people to make the best choices they can. And so, I think we should just keep, hounding on, if you have questions for your own personal decisions, get advice for your family. And I'll just say the Office of the Healthcare Advocate is a free resource. And there's no income eligibility. All you have to be is a Vermonter. And even that we stretch sometimes. There are Vermonters who are away at school, for instance. And so, 800-917-7787 is our phone number. And, if you have questions, if you have things that are not quite working, feel free to give us a call.
Thank you, Mike. And yes, their service is wonderful. I don't know about other people out there, but I go through the healthcare forms and everything. It's snowblind after a while. So it's nice to know there are people in the state who that's their job, is to walk us through these problems. So thank you.
And let me also say, I also have a caution about taking advice from somebody who's trying to sell you something.
That's probably always good advice.
Yes. And so we're not part of an insurance company. We are, connected to the state because we're funded through the state and defined in state statute, but we're not Vermont Health Connect. We're not Blue Cross. We're not UVM. We're not a hospital. We are intentionally independent of all those parties.
Thank you. Well, Mike, let's kind of start there, since we are in the season of open enrollment and the Medicaid redetermination process. Yeah. Can we start there? What's happening right now for a lot of people?
So I don't know if anybody remembers the pandemic.
I do.
Because of the pandemic, the federal government, I think, did a great thing. It said, hey, states, you can't cut anybody off of Medicaid. We're going to give you some extra money. Give you a bump in your federal match rate, which is a lot of money. But you can't cut anybody off of Medicaid during the public health emergency. That lasted for a little over 3 years. But then at the end of that, the federal government said to the states, okay, it's time. You have to get back to your regular roles and make sure people who are on Medicaid are really eligible for Medicaid. During those 3 years, we had women who got on Medicaid because of their pregnancies. continue to be on Medicaid, for 3 years after their pregnancy. So there are clearly people who continued to be on Medicaid who were no longer eligible. So that's what the process is.
People who got laid off temporarily because
Sure.
their business shut down and then they got a new job.
Sure, exactly. So the federal government said you have to do it in the course of a year. And so they divided in Vermont, a little over 200,000 Vermonters into 12 bunches. And so every month, a new group of Vermonters gets gets outreach and gets notification and reminders that they have to be in touch with Medicaid to make sure they're still eligible.
And how far into the 12 months are they?
I think March is the last regular month, so we're well on our way. March followed by about 2 months of managing the case, finishing the process for people. But the main thing to say to people is, hey, if you get a letter or a text or a card from Vermont Health Connect about your Medicaid, it's something to respond to. It's something that you kind of have to deal with. We have been pretty upset by the number of people who are getting closed because they don't respond. I'll say I can be critical of Vermont Medicaid for things that I think they haven't done quite right. But I also have to recognize the federal government has said you have to do it. Mm-hmm. And they are sending texts and doing all kinds of outreach. And so, if you haven't gotten a note, if you're not used to having an annual redetermination, Vermont families aren't used to it and maybe have moved. So it's a tricky job to reach out to that a little over 200,000 Vermonters.
Mm-hmm. And if people do get that card, any thoughts? I mean, they have to respond, but anything that might help the process go more smoothly?
Yeah, I think respond quick. Recognize that the state system for fielding phone calls is overwhelmed. We know that the helpline that the Vermont Health Connect phone line can have very long wait times. It's very frustrating. So call at 8 a.m. If you don't want to wait a long time. If you wait till 3 p.m. on a Friday, you're going to be on hold for an hour.
Little known state government secret: state employees work from 7:45 a.m. to 4:30 p.m. I don't know why. It's kind of ridiculous for the actual humans who have to do it. But it does mean that services are available at 8 a.m. if that's what you're looking for. So
definitely asking people to attempt to negotiate the system on their own, make the phone calls and respond, with what's needed. If something doesn't go right, if you feel like the state is not responsive or is getting something wrong or there's something messed up about your case, we are also a resource for that. And so, if you need to be pointed in a good direction on it, or you need some assistance because of something that's messed up, and things do get messed up. Let's be clear. I'm going to give that same number again, 800-917-7787. You can also look us up online, and we have an online help tool, so you can also write it down to us. We're trying to help people through the system.
And so let's say someone is not eligible for Medicaid anymore. And so they now are going to try to find insurance in the marketplace. What does that look like for them this year?
So There's overlapping issues because we are also in open enrollment. But aside from the regular open enrollment period that we're in, somebody who loses their Medicaid because they become ineligible at any time of year gets a special enrollment period for them and their family. And so,
and Mike, that's true anytime anyone loses insurance, right? It's not just losing Medicaid. It's like if you lost a job or.
That's right. That's right. Or you lost your insurance because of a divorce, yep, or a move, or you turned 26 and had to come off of your parents' plan, or anything like that. It's the same system here in Vermont. Vermont Health Connect does both Medicaid and the private insurance companies through the exchange. If a family finds there are really substantial supports for people. I'll just say it again, really substantial supports. I think, don't panic. There are, both federal tax credits and state and federal cost sharing subsidies to help people who are, low income, but just above Medicaid.
So, Mike, I was recently sort of like wondering about the idea of buying a new car or a used car, just like a car that was new to me. And one of my colleagues had just gotten a new car and is very involved in the transportation industry and transportation policy, and told me about like this just remarkable way they were able to stack tax credits and make their car be a reasonable price. And I just like was kind of overwhelmed at that idea and wanted to crawl under the table, even though, I'm hypothetically a tax credit aficionado. And so when someone is buying insurance, like, how do you figure out the difference between like the scary number that I read about in the paper and how much things will actually cost me?
So on Vermont Health Connect, there are tools that you plug in to to estimate your income and your family size. Hopefully it's not an estimate. But the wild card in this calculation, different than a car, the wild card in this calculation is how much healthcare do you think you might need in the next year? Now, if you're 28, and you're fit and you're healthy and you don't have ongoing problems, it's not unreasonable to say, hey, I don't think I should go to the primary care doc. I should get a checkup, but I don't expect to need much more than that. This is the wild card, Emily, the hardest thing for people to really figure out, because as we all know, you can step off a curb, you can sprain your ankle, you can have an accident, or you can get a bad diagnosis at any time of your life. And so this question about, sort of generally, do I want to pay more in premiums and have to pay less in out-of-pocket costs if I need care? Or do I want to pay less in premiums and have more exposure, more potential out-of-pocket costs if I need care? That is the wild card in that calculation.
And the whole like out-of-pocket costs versus deductible versus copay, how does that sort of fit into when we see that our rates are increasing? Like, how does that all fit together?
Well, I use the term out-of-pocket costs to group together deductible and copay and coinsurance. There are three different versions at the end of the.
Wait, what's coinsurance?
At the end of the day, it is all money coming out of your pocket when you get care, not when you pay your monthly premium bill. A deductible is an amount that you pay before you get coverage. It can be, $700 or $500 or $15,000. It can be a lot of money. And copay is sort of a fixed amount that you expect to pay. I'm going to pay $20 when I go to the primary care doc kind of payment. And coinsurance, I think, is less common in these plans, but it is sort of a percentage of the care above the deductible that you're going to continue to need to pay. The best example of something that's like a co-insurance is in Medicare, where and Medicare is for older and disabled Vermonters, Americans, Vermonters, people who are over 65, or eligible for Medicare due to a disability. Generally, Medicare pays 80% of the cost of care, and 20% ongoing with no maximum is out-of-pocket cost. So for people who think, everything's great, I'm on Medicare, I don't have to worry anymore. Medicare only covers 80%.
Right.
We all still have to worry every day.
So you still need to buy, people still need to buy, if they can afford, a supplemental plan.
And is Medicaid ever a supplemental plan to Medicare?
Well, sure. In effect, for people who are poor enough, and I maybe this is an opportunity for me to recognize, people think you say the word Medicaid and it covers sort of, I know what I'm talking about. There's one program for Medicaid. Not so. There are many, many complicated different programs that we call Medicaid. And, people might know the difference between Dr. Dinosaur versus, what we generally call Medicaid. I'll say Medicaid for children and adults, MCA Medicaid. So that's we say here in Vermont that your family can have much more income and still get coverage for kids and pregnant people than the income eligibility for for families. And I wonder if I can give you a number. So if you're, I'm not going to try and do math.
Not at this hour of the morning.
That's right. Yeah. But the starkest difference that I think most people don't know is that the Medicaid program for people on Medicare, that is called MABD, Medicaid for the Aged, Blind, and Disabled, is we've left that population behind. The whole Affordable Care Act, and Vermont has a long history before that of really trying to improve access for younger and non-disabled Vermonters. Remember the Catamount program, remember VHAP, and certainly Dr. Dinosaur. All of that is for non-disabled under 65-year-olds. And we have not addressed the policy area, the need for a Medicaid expansion for people on Medicare. And that's what I'm wanting to talk about in the second half. And I couldn't stop myself from doing it now.
Okay, so scary headlines, percentages are increasing, costs are increasing, inflation's increasing. Last week we talked about the cost of schools right now. And one of the big pressures on the cost of school budgets is health insurance premiums. What is the story? How can all of that be growing so much faster than inflation? We know that a lot of inflation, like food cost inflation, is actually corporate price gouging and not like natural growth in the magic economy. So what is the story?
So, I think that most people want to sort of tell the story of the big bad boogeyman of insurance executives. If we were talking about some national actors, some for-profit actors, I would join quickly in that profit taking. Hey, my job is to go up against Blue Cross and MVP in the insurance rate review process. And my office fights hard against the rate increases every year. So I do think there are things we can do to bring down the cost, but by and large, I got to admit, the reason rates go up is because costs have gone up.
So that's so confusing to me because as I sort of like hear the corporate healthcare national narrative, I want to jump on board because that's fun and satisfying. And I know that our healthcare in Vermont is like, incredibly closely regulated. And I know that our health insurance companies are nonprofits. And so I get very lost, and like our hospitals are all nonprofits. And so I get very lost and confused about where the money is going.
So there's nothing simple about this. Apologies.
No, that's why we have a whole hour.
That's right. So it's true that, Blue Cross and MVP are nonprofits. And it's true that we regulate them, that we have maybe one of the stronger regulatory systems in the country. But the majority of Vermonters in private health insurance are in what's called a self-funded plan. And so, their employer is purchasing, is in effect self-insuring and purchasing.
Really, the majority of Vermonters?
The majority of privately insured Vermonters.
Okay.
And strong majority. I don't have the numbers in front of me, but it's a lot of people. And that is not regulated. We are preempted by federal law. So I can't say to Emily, pass a law to do something about something that's wrong for this marketplace, because it's the federal government, and Emily, as our state representative, can't do anything about it.
Well, it's funny, Mike. I think that health care policy is probably the area of sort of like legislative jurisdiction that I know the least about. And I think part of it is I showed up in the legislature and I was like, oh, wait, we can't actually control all the useful levers. I think I'm going to go off and do something else. And then, so I was like, oh, I'll focus on tax policy where we also can't control any of the useful levers. So I don't really know what I was thinking, but it is so confusing to me that we have this really strong regulatory regimen, and yet we are where we are. And it seems, now that I am the chair of Ways and Means, in fact, I do have a healthcare oversight role. Turns out there's a committee called the Joint Healthcare Oversight Committee, HROC, Health Reform Oversight Committee, HROC, which it turns out I'm on. And we had a meeting this fall for the first time in a while. And I was very struck by how much faster our healthcare costs are going up than it seems like the national norm. One of my colleagues asked a question that is where I'd been heading, which I wanted to just like write that all off to our aging population. And I was told that wasn't appropriate. And so like, Mike, what is the story?
Yeah, it's pretty upsetting to look at the rate of growth in healthcare spending in Vermont compared to the rest of the country, and it's hard for me to draw a simple conclusion other than we have not been holding, in my opinion, healthcare providers' feet to the fire. And really saying, hey, this is tough. These are tough decisions that you have to make. But somebody has to pay when costs go up. And, and again, I can be all kinds of critical about details of it. But I'm going to try not to go there now. I think that, because of how separate, when you're buying a car, or even, let's make it simpler, when you're buying a tire, who's paying, and you get to shop and you say, here's the cost and here's the, but in the world of health insurance, and so, you can say.
Do other people shop around for tires? Because I go to the same tire place all the time and I buy the tires that he tells me to. So I don't even know if this is a good example, but let's continue on. Sorry.
But sort of the concept, if you're selling a tire, the concept of the marketplace will allow me to raise my prices X amount. In the world of healthcare, because you have this middleman of the insurance companies, and the confusing part we talked about earlier, that people are trying to make a decision about how much to pay for in premiums and how much to be exposed at out-of-pocket costs. How does the market respond when UVM raises its prices by double digits? It's less clear. And by the way, I know you got to get a tire. You just got to have a tire to run your car. But it's the dynamic of healthcare and people's need for care to keep them healthy just makes it a different equation. I'm not sure I'm making the sense I want to make about this. It's expensive. It's expensive largely because we want care, and because I also think because we haven't held hospitals' feet to the fire over the last number of years. I think one of the slides I think that were put in front of your committee last week, was that last week? Was just recognizing that in Vermont, hospitals have gotten, I think it's 98 or 99% of what they've asked for over the last number of years.
Well, that's a question I have for you. So my first...
Hey, Emily, actually, I think, can you hold that question till after the break?
No. Yes.
Yes, please.
I can.
Because unfortunately, we are out of time in the first half of the Montpelier Happy Hour. So we're going to hear from some underwriters and then resume our conversation with Representative Emily Kornheiser and Mike Fisher from the Office of Vermont Health Care Advocate. So stay tuned. We'll be right back.
Too quick.
We should rein ourselves in, though.
Welcome back to the second half of the Montpelier Happy Hour here on WVEW 107.7 LP Brattleboro, our community radio station. You can also find us, thanks to BCTV, on many of the public access stations around Vermont and a little bit in the rest of New England. So we want to thank BCTV for their help on sharing the video version with the television stations. And Emily, what do we need to remind listeners of?
Well, Olga, as a matter of fact, the views and opinions expressed here on the Montpelier Happy Hour are those of the host and the guests, respectively, and not the station, nor their employers, nor friends.
Lovely. Why, thank you. And if you're just joining us, I am your host and producer of the Happy Hour, Olga Peters. I'm speaking with Representative Emily Kornheiser, one of three from the town of Brattleboro, and Mike Fisher from the Office of the Vermont Healthcare Advocate. And we've been talking, surprise, surprise, about healthcare and costs and how sometimes that just seems frustrating. We can't see where our money's going. Right before the break, Emily, you had a question for Mike that I needed to cut you off for time reasons. Would you like to ask that now?
I would. So before the break, we were talking about how recently I was in a meeting and learned that we are spending more and other states. And my first instinct was our regulatory project has failed. And then my second instinct was it's because we have so many older Vermonters. And then that wasn't right. And now my third question is maybe it's not actually that we failed. Maybe it's actually we're failing less than other states because so many other states have shut down vast swaths of their healthcare system. And so I know out west, rural hospitals have shut down really across the board. And so access to care, which feels hard here in Vermont on the regular. My dad just moved here and has a lot of healthcare needs and has spent many months now attempting to even find a primary care doctor. But maybe it's actually that we are doing better on access because we are piecing together to keep our hospitals open. And so you can just tell me that my hope is wrong, Mike, but what do you think of that question?
No, I think your question sort of points at the complexity of it all. You're right. Vermont scores well on the quality of our healthcare system. and the health of Vermonters. Now, that's for a lot of reasons. Some of them, many of them cultural, but in my office, we argue both sides. People need access to the care they need, and the cost is too much. But I think this whole sort of theoretical conversation about how much it costs, and the kind of stuff you hear when you're in a legislative committee about healthcare costs, I think is a step too far away from regular people's experience for me.
Mm-hmm.
I think we often talk about in terms like people get the right care at the right time, and we in health policy, that things are better when people get the right care in the right place in the right time. But my experience is that more and more Vermonters are forced into making economic decisions, not healthcare decisions. So they go to their doc, and their doc says, "I think you really need this. You need this medicine, or you need this test, or you need imaging, or or maybe you don't even go to the doc because you already have a bill." And that's where a major place where we feel like this system is falling apart for regular people.
Mm-hmm.
And that is, of course, a combination of cost and the systems of support we have for moderate and low-income people.
Thank you for saying that, Mike. I think for I don't know if this is true for you or Emily. I know for me, a lot of stress around healthcare. It still feels like, despite getting the healthcare plan, and despite your premiums and everything like that, your copays, healthcare costs still feel unpredictable.
Yep.
And not just like, oh my gosh, I fell down a ladder and I broke my leg and I wasn't expecting that kind of unpredictable. Just like the cost of prescriptions change, and that unpredictability when you are living on a tight budget. Yeah.
It's really scary.
Yeah.
Mm-hmm.
It is really scary, I mean, what we hear from people is that they love their doctor, that they appreciate the care they've gotten, that they think their provider, doctor, or whatever needs to be paid, should be paid, and they also know they can't do it, that they have bills, or that they're afraid of the bills that will come, and that ends in many people saying, "I'm not going. I've got this going on. Maybe it'll get better." And so, from a health policy perspective, we generally think upfront, downstream care, preventative care is what leads to better outcomes and less expense. And the cost of healthcare is interfering with that. The cost on the consumer side.
Right. Yes. So from your perspective, as someone who hears a lot of these stories every day from people, where do you feel policy could change or should change?
So I started to talk about this in the first half. We feel like we have really left behind older and disabled Vermonters. And I say we, I just want to recognize, I'm not pointing my finger at anybody, any current policymakers. Me
and
too.
Full disclosure, Mike, you had your time in the ring, yes?
Yes, indeed. Full disclosure, I was chair of the healthcare committee for a while. I was in the legislature for 14 years. And I want to recognize that we policymakers have focused so much on non-disabled under 65-year-olds. We still have more things we should do for them. I'm not suggesting in any way that we've achieved, the right place in support for low-income younger Vermonters, but we have forgotten about older and disabled Vermonters. So, just as an example, if you're under 65 and you want to get Medicaid, the income limit for regular Medicaid, if you're under 65, is for family of one is $1,676 a month. 1,600. Happy birthday! You just turned 65, and you turn around and you suddenly realize I'm no longer eligible for Medicaid.
Wow.
Let's say you're $1,500 a month of income. Happy birthday. Suddenly the income limit for the Medicaid program that supports people on Medicare, that covers cost sharing, is $1,200 a month. And so that is a result. The Affordable Care Act nationally really sort of held states. It encouraged and supported the funding of Medicaid expansion for the younger non-disabled people, but it didn't touch the Medicaid programs that for older people. And I'm using the term Medicaid a little bit loosely here. I'm saying Medicaid programs. There's a thing called Medicaid for older people, MABD, but there's also something, a Medicaid program that wraps around Medicare, that goes it goes to 100% of the federal poverty level, and covers cost sharing. And I'm flying high. There's other programs that cover Medicare premiums, which are also very important and very supportable, but for the moment focused on full coverage. And then also, hey, that's the health policy. You hear me talk in health policy terms of, what happens when people don't have access to care, but this is an economic justice issue too. Who is poor and retired? Well, it's people that didn't earn as much through their lifetimes. Well, guess what? Women, people of color, certainly people who are lived with a disability, don't have access to the same earning potential. And let me just focus on women for a minute. I know it's more complicated than this, but it wasn't that long ago when women earned the right to have a bank account.
Yeah, it was not that long ago. It was the 80s. Like, it's just, credit cards were the 80s. Like, it's a wild thing, I think, for folks who didn't live through it, how recent history that was.
So I'm not sure I have the math in front of me, and I shouldn't try and do it right here, but for the 70-year-old, they lived their lifetime. And of course, we haven't caught up now. Let's recognize we're not, we haven't achieved equality now. But for the 70-year-old, she has lived her life through a time period where substantially less access to income, and family dynamics and expectations to take time off from work in order to raise children and care for elders and the like. And so, hey, we see
retirement, the Social Security earnings for women who are on Social Security right now are significantly lower. Not set aside regular, extra retirement.
And I can give a few numbers there. Women over 65 in Vermont have an annual income of about $11,000 less than men. 44% of senior women don't have enough income to meet basic expenses. And Social Security, since you mentioned it, women's lower earnings result in Social Security benefits that are 59% of what men earn. And so the bill that we're pushing to increase access to full coverage for healthcare disproportionately, it helps all Vermonters. But because women and people of color and people who have lived with a disability are disproportionately poor, the bill does target this inequity that we've been living with, and do a little bit to right this wrong.
Does the bill you mentioned, or the effort you're pushing, does it have a name, just so people could follow it in the news, that type of thing?
So it is H181 is the House version. Let me make sure I have that right. I'm sorry, I did not. 118. And there's a Senate version, S61. And it raises the income eligibility for a program that's called MSP. And I apologize, everything in healthcare is misnamed or is confusing. MSP is called the Medicare Savings Program. And then you're going to say, wait a minute, I thought we were talking about Medicaid. It is called the Medicare Savings Program because it wraps around Medicare. It is a state, it is a state federal partnership with a match rate like other Medicaid programs. So we are seeking to raise the MSP limits to make up some of this ground, avoid the cliff I talked about earlier. You shouldn't turn 65 or become eligible because of a disability and suddenly discover you have less care, less support for care. There's my pitch, and guess what? It's not cheap. It does have a real expense, but
Mike, so if Medicaid is a federal program, and this is like, I know the answer to this question, but I'm asking you for the general public. I just feel like I should close that part. Then like, why can't we expand it to all the places we want to expand it? And the feds will pick up the bill. How does that work?
Well, it is a federal state partnership. I don't remember exactly what our match rate is. We get maybe 55 cents on the dollar ish for Medicaid programs. So the feds are paying about 55 and the state's putting in about 45. Emily, I don't know if you have that number in your head.
No, I don't know. I don't ever.
But
little known secret about the chair of the Ways and Means Committee, I do not retain numbers.
Yeah.
They just graphs. If you give me a graph, I will remember the whole thing. But
so the state doesn't get to do anything it wants in Medicaid policy. It has to get federal approval, and the feds do care about where they put their money. Mm-hmm. But I got to tell you, a couple of our neighbors have done some heroic work here. Maine just passed a bill last year that substantially improves these programs.
Maine is the other oldest state in the country, just for our listeners who are not mapping their demographics across their geography.
And New York last year, or maybe it was the year before, did a substantial improvement here. Massachusetts, Connecticut, have all are doing much better than us.
So it's possible, in other words.
Yes. So, and and this is the tough thing that I get to say as an advocate to legislators. It does cost something, and it does have to do with where our priorities are. Mm-hmm. And I know that we don't have enough money to do everything we want to do. I know that, and fully recognize that. My job is to put forward things that I know that the legislature, that's challenging to do. Mm-hmm. By the way, we got to deal with housing and education and everything else. And I know it. I've been in those shoes before.
Well, and we know that when we deal with housing and education, we actually even save healthcare costs down the line, right? Like the biggest,
and vice versa.
Yes. And one of the biggest drivers of, good health is actually good housing when you're younger. I have to ask you, Mike, I'm the representative from Windham County, from Brattleboro, right? We are the heart of the Vermont Worker Center movement down here in Brattleboro, and a bunch of other advocacy organizations. And so you've been in this for a long time. You've thought about this really deeply. It sounds like your ask this year is still nibbling around the edges. Why can't we really go big?
Yeah. Well,
and what does big look like, Emily? How would you define big?
well, let me answer that. Hey, I was chair of the healthcare committee when we were trying to do government financed healthcare. That was big. And, we ran up against a brick wall, and we could spend a whole hour talking about why that happened.
Can we do that
But
actually in like a little while? That would be fun.
sure, I'd love to.
Okay.
Maybe get Robin and I on. I think that'd be fun.
Mhm.
Um, 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 so people who are advocating for a whole system reform, and who say you can't keep nibbling around the edges, we have to fix this system, the whole system. I'm afraid you're right. I mean, I know you're right. And I also, as the healthcare advocate, I also have to recognize the political realities. Who is our governor? What is our partnership with the feds? Nothing simple here. And so while I'll always be a supporter for, broad system, healthcare finance system reform, I also, have to take the steps that are in front of us. To the family we were talking about earlier, the $1,500 a month earner family, to her, the change that we're proposing is not minor. It is not nibbling around the edges. It's saving her life, quite literally. And so,
Thank you.
So, that's the push and pull that we always have to do in health policy, and in every policy. Sometimes we can't do everything we want to do. We should still be pointing at it. We should still be working towards it. We should still be offering proposals to go all the way. And we have to take the steps that are available to us today. How was that for answering the question?
Thank you. I appreciate it.
Yeah. I just want to say really briefly, recognize that this proposal to raise the MSP limits has a lot of broad support. The Vermont NEA, the Hospital Association, the Worker Center, Disability Rights, Blue Cross Blue Shield, by State Primary Care, and Alzheimer's Foundation. And I am sure I am leaving off a couple who are going to say, how come you didn't mention me?
Because everyone the show, especially the last 52, minute 52 of it. So I'm sure someone heard you leave off.
Yeah, businesses for VBSR. We think we don't have the final okay, but we've been talking to Vermont Commission on Women. So there's a lot of broad support for this proposal.
We have just about 5 minutes left in the show. Are there any other proposals you're putting forward that you'd like to mention?
Well, I'm gonna say I have a proposal that we've put forward that I think is not ready.
Okay.
But I want to mention it. I think it's 3 years ago, we put forward a proposal that the legislature passed. Thank you, Emily. To create a state program for undocumented children and pregnancies. That program took a little while to get up and running. It is up and running, and doing some real good. We think we have some work to do to help it run better, but I have always felt like a next step. Like I understand why we do pregnancies in children first, but that leaves a whole group of non-pregnant adults who we're not giving access to care, and so we do have a bill that we've introduced to do just that. It sits on the wall in House Healthcare and in Senate Health and Welfare. We, to some degree, Emily, I'm looking for a way to tee that up for next year. I think I need to give Medicaid a little bit more room to finish setting up the system. And I also recognize that it also costs money. Because now we're talking about not a state federal partnership. We're talking about a state only healthcare access. So,
I mean, I'd be curious how much it does cost, because one interesting thing that happens to me when I go to national conferences is that we've expanded a suite of low-income tax credits to undocumented folks. And it really like doesn't cost much of anything in the grand scheme of tax policy. And so it's really interesting to go to these national conferences, feel like celebrated and wowed for our groundbreaking work in Vermont, but know that it was actually like a really easy political win, because we didn't really like, it was in some ways gestural. I think it'll make a real difference in some people's lives, but there weren't sort of tough decisions connected to it. And so I'm curious sort of how you see the landscape there.
Yeah, I think that's a good question. I think we're going to run out of time, but I think you also have to recognize when people get sick, at least when people need emergency care, they go to the hospital and get care. And so if they are low income, whether they're documented or not, they can't pay for it. And it goes to the bottom line in uncompensated care. And so, the question becomes, do you believe that giving people access to care up front saves money? And I do. I believe it's the right thing to do on a human level. And I also believe it's the right thing to do for outcomes and expense. And hey, a lot of the people who are here working in our communities without documentation are on the farms. This is not a safe job.
No.
And they get hurt.
Yeah. Thank you, Mike. Emily, just in the last couple minutes that we have at the break, I think you had mentioned social determinants of health. Is there anything you wanted to tie into this conversation with that? I mean, you touched on it with housing, but.
Yeah, I think it's sort of broadly understood that, and maybe not, but just want to sort of name really explicitly that the biggest driver of someone's health is not actually health care.
Right.
It is housing circumstance, education, income, and then that winds up being costs on the other, near the end of life. And so when we've been having conversations, especially about housing and how we pay for housing, there's a lot of emphasis around how Medicaid can fit into that, and how we sort of save money upstream in our healthcare system. And so just sort of wanted to like name that that's an interesting piece of this puzzle.
Yeah, and I would join with you. It is one of my sort of nagging pet peeves, is the wrong, that implies that it's small. My nagging frustrations. We know, healthcare 101, we know that what contributes to someone's health, to the health of the community, has little to do with what happens in the clinical setting. It has to do with all the things you mentioned, plus environment, plus I don't know if you mentioned access to good food.
I did not.
Yeah, and we know what it is, and yet we put all of our energy into figuring out what to do better in the clinical setting. And maybe I should say all of our energy, because I live in the world where we focus on that. But what you're suggesting, or my takeaway from that, is that we really need a true public health frame in how to help Vermonters get healthy and stay healthy. And I think there's a lot of models out there. This is people know how to do this. And I just think it's a very different question to say, how do I treat the people in my panel? I'm talking as a doctor. How do we treat the people who go to this hospital who have diabetes or who have depression, versus how do we treat the community? Our community is sick with anxiety and depression. X%, 7-8% have major depression. That's a lot. how, what's the right way to treat our community to improve people's lives is a very different question. It results in different answers. And I think we in this country and this state have devalued and defunded our public health infrastructure. That's a big system-wide reform frame.
And I think it's a particularly poignant one in these times where we're about to really think very deeply about how we fund and construct new housing, what the role of our public schools are and can be for sort of solving society's ills. As we recover from COVID and think about sort of what people need to be, healthy in their communities. Yeah.
Well,
thank you.
Thank you, Mike Fisher from the Office of the Vermont Healthcare Advocate. For those who listen to the podcast, I'll be linking to the contact information in the show notes, but it would be great, Mike, if you would remind us one more time of that 1-800 number.
1-800-917-7787. I've gotten good at that one.
Yeah, you're like,
thank you.
Yeah.
And Emily, if people want to find out more about you or get in contact with you, how can they do that?
Folks can go to emilykornheiser.org and you'll find links to all the ways to be in touch. I would also like to make a public service announcement that there are free COVID tests at the Brattleboro Library. And despite me saying this many times, none of my even friends seem to know this. So I just want to say it again. You don't need to buy them at Rite Aid. They are free at the library.
And that's Brooks Memorial Library.
It is indeed, but maybe other libraries have them for free too. I don't know. I just know that the Brattleboro Library is wonderful and has free COVID tests.
Thank you, Emily. Well, as always, the Montpelier Happy Hour is on WVEW 107.7 LP Brattleboro every Friday at 2 p.m. and rebroadcast on Wednesday morning. And you can also find us wherever you subscribe to your podcasts. So have a great weekend, everyone. Take care.
Thank you.
Thank you.